Good evening, everybody. My name is Jenny Pearson, and I'm an Education Officer for the Primary Health Network. Thank you for joining us for the right medicine paths out of opioid use. This is our last webinar in a session that we have done on alcohol and drug use. Before I go any further, I'd just like to acknowledge the traditional custodians on the land that we meet on tonight and pay respect to elders past, present and emerging. At the end of the webinar tonight, an evaluation will pop up and we would really appreciate it if you could just take a minute to fill it in. That would be great. Before we do get started tonight, we do have some polls. So we've got 3 questions that we're going to ask you. They'll pop up on your screen and there's a multiple choice for you to choose from. And then at the end of the webinar, we'll ask them again and see how much you've learned. So I'm just popping up the first one now. Okay, looks like everybody's answered that. And I'm just going to share those results. So would you take over the care of a stable patient's opioid treatment who you were already seeing in your practice? So 83% have said yes and 17% have said no. I will just launch the next one. Thanks everyone, and I'll just share those results. And I'll just launch the last one. I'll just share those responses. Thank you, everybody, for participating in that. We have a GP chair tonight, who is Dr. Lauren God. She's a GP in Newcastle. So I'll just hand over to you now, Lauren.
Yeah, hi everyone. Thank you very much for attending tonight's Education Centre session, The Right Medicine Paths Out of Opioid Use. My name's Lauren Goody. I'm a Newcastle-based GP practicing at Broadmeadow Medical Centre. So tonight we have three presenters talking about opioid use disorder and the management of this. Firstly, we'll have Emma Penny, a clinical nurse specialist with Newcastle Drug and Alcohol, John Jones, a pharmacist at My Community Pharmacy in Shortland, and Dr. David Outridge, a GP and addiction medicine specialist. If you have any questions for our presenters tonight, please write them in the question box and they'll be asked at the very end of the presentations. So first we have Emma presenting on prescribing treatment and transitioning from tertiary care to primary care.
Hello, so my name is Emma Penny and I'm a clinical nurse specialist and I work for New South Wales Health Newcastle Drug and Alcohol Clinical Services. Firstly, I would like to show my screen. Are you guys going to do my slide?
Yes, so I have got it up. Emma, can you see it?
No, I can't see it. That's okay. I'm happy to just talk.
No, that's fine. Can you see it now?
Yeah, now I can see it. Thank you. So you can go to the next slide. Thanks. So we're going to be talking about prescribing treatment and transitioning from tertiary care to primary care. And to the next slide, please. So first I'd like to acknowledge the traditional owners, the Wabga people on the land that I'm speaking on today, and pay my respects to the elders past, present and emerging. Next slide. And I don't have any conflicts of interest to declare. And next slide. Thanks.
Sorry.
Okay. So the learning outcomes today. So at the completion of hopefully my talk of this webinar, you'll be more familiar with the Newcastle Pharmacotherapy Specialty Service that I work for, and familiar with a shared care approach from Newcastle Pharmacotherapy to primary care and back, and also more familiar with the roles that GPs play in prescribing opioid treatment in primary care. So the next slide, please. So I'm going to talk a bit about our service. So it's an important thing to remember the significant harms that are associated with unstable opioid use. So just some figures that I have here. You can go back to that other slide. So in 2018, there was almost 1,600 unintentional drug-induced deaths in Australia, with about 900, so almost 60% of those were opioid related. There's also been an increase in pharmaceutical opioid deaths, which have largely been reported as accidental overdoses, and sadly most reported overdoses are male, who are 3 times more likely to die from an unintentional overdose, accounting for about 71% of people in 2018. And also, sadly, from the 2018 figures, Aboriginal people were almost 3 times as likely to die from an unintentional drug-induced death compared to a non-Aboriginal person. Next slide. So opioid use disorder is a chronic health condition that affects a person's physical, mental and social well-being and affects a number of Australians every year. In 2020, there were over 50,000 Australians in some form of opioid substitute treatment, which was about a 5% increase from the previous decade. So not everyone who takes opioids develops a dependence. There are multiple risk and protective factors to determine the likelihood of dependence, such as one's biological, psychological, social and cultural factors. Although the prevalence of people with an opioid use disorder is relatively low, the harms, costs and consequences are high, making opioid dependence a major focus in drug treatment services. Costs associated with fatal overdoses, prevalence of hepatitis C, B and HIV, social consequences to individuals and their communities, and the cost to healthcare, law enforcement and judicial systems. Opioid use disorder is not only for people who inject drugs. So due to the increased use of pharmaceutical opioids in the last 20 years, there's been a rise in patients presenting to our service for help with pharmaceutical opioid dependence and in such managing their chronic pain. It's also probably a good time to mention that in August, Hunter New England Health and Central Coast Health will be the rollout sites for SafeScript New South Wales. So that's the real-time prescription monitoring. And we're expecting that to have quite a big impact, not only on our service, but on the healthcare in this area. And we have a broad goal of reducing harms related to opioid use. In opioid treatment can lead to psychological stability, improved and control over drug use and eventual abstinence from opioid drugs. And there's also strong evidence that long-term treatment is needed to be able to remain stable. Next slide, please. So as you can see, there are a number of approved medications for the treatment of opioid dependence. Methadone, which is an oral liquid, comes in a brown and a red solution. It's 5 milligrams of methadone per mil. Suboxone, which is buprenorphine and naloxone sublingual film, and they come in 2 milligram and 8 milligram strengths. Subutex, which is buprenorphine sublingual tablets, and they come in a variety of strengths there, 0.4, 2 milligrams and 8 milligrams. And then we have our new, in the last couple of years, depot buprenorphine injections. So there's Sublocade, which is a buprenorphine depot injection, which comes in monthly injections of 100 milligrams and 300 milligrams. And Buvidal, which is another buprenorphine depot injection, which comes in weekly and monthly formulations. There is 8 milligrams, 16 milligrams, 24, 32 for the weekly, and the monthlies are 64, 96, and 128. Next slide, please. Thanks. So what you can see here is, so these are the pharmacotherapies that we provide with Newcastle Pharmacotherapy Service. And there's a total of 566 patients in the Newcastle, Lake Macquarie, Maitland, Port Stephens area. And this is kind of the breakdown of what we prescribe and what our patients are on. So with the rollout of depot buprenorphine in the end of 2019, we saw a massive shift in the treatment provided to where now over half of our patients are on some form of buprenorphine. Prior to 2019, this was not the case. Most of our patients were on methadone. So our service, it does also provide treatment to other areas in our local health district, such as Cessnock, Tyree and Tamworth. Next slide, please. So Newcastle Pharmacotherapy Specialty Service. So we're primarily a stabilisation clinic. So our main aims are to stabilise patients from the community who may be in crisis and require immediate support and case management to treat their opioid use disorder. Another aim is to commence patients on treatment from multiple access points. So we get referrals from the justice system, acute care settings, self-referrals, other service referrals, general practitioner referrals, and other specialist referrals. We aim to maintain care and treatment of patients who have complex care needs. We aim to transfer stable patients to primary care for ongoing opioid agonist treatment, and we aim to restabilize patients who have become unstable while with a primary prescriber. Next slide, please. So our service is designed to primarily be an initiation and stabilization clinic where we can provide access to treatment without delay to complex and high-risk clients. Unfortunately, due to the high number of clients on our program and due to the frequent number of people being released from New South Wales prisons on opioid treatment, of which we get about 10 a month, we're unable to quickly take on new clients. So the time passed between a person's first presentation or referral to the start of treatment can take anywhere from about 14 days to 2 months. So during this waiting period, these patients are often at risk of opioid-related harms and overdose. It's a good time also to mention take-home naloxone. So take-home naloxone can and it does save lives, and it can be prescribed by a GP for any patient. There are some pharmacies that do take-home naloxone without needing a prescription, as well as our service will give out take-home naloxone to anybody without a prescription. So take-home naloxone can be prescribed for anyone who is at risk of overdosing on any type of opioid, or to anyone who may witness an opioid overdose. This could be for people who are on high doses of opioid pain medications, using illicit opioids, maybe returning to opioid use after a period of not using them, as well as those people of friends and families of those who are using opioids. Next slide, please. It's just another pie chart that I've created. So this one is looking at, with our almost 600 patients that we see, we categorize them into care zones. So this is kind of a picture of what the patients that we have on our service. So obviously we've got 16% of these patients have really high treatment needs. So these are the people who are unstable and they need a lot of monitoring and care that we provide. Then there's another 24% that have medium treatment needs. They might have reduced their polysubstance use or have stabilized some areas of their life but are still requiring some more frequent contact from us. And then we have this really large chunk of people who are about 60% of our patients who have low treatment needs. So these are people who are adherent with their treatment. They don't have any intoxicated presentations. They have no significant use of other substances. They have no mental and physical health problems. They're not pregnant and they don't have any significant social concerns. So yes, so 60% of our clients are care zoned to this low treatment needs area, and more than half of these patients have a regular GP that they see. It's also important to flag that a significant number of our patients are not heroin users, which highlights that opiate use disorder is not just someone who uses IV drugs and has multiple social issues. It's also people who have chronic pain and have become addicted to opioids that they were prescribed. Within this green section, there's about 12%, about 80 patients who are separated from the low treatment needs group, and they're what we call our ultra stable patients. They're ones who work full time or just regular people in the community that you would never know were on opioid treatment. So there's about 80 of those patients who we look after as well. Next slide, please. So Dave is a 38-year-old man who is stable on subcutaneous buprenorphine long-acting injections. He owns and lives in his own apartment in Newcastle, works full-time as an accountant, and has 2 children that he shares care with his ex-wife. Dave has a regular GP who he sees nearby for regular health checkups. So Dave is in that low treatment category needs, and he's in that ultra stable patient group that I was just talking about. So here's somebody who we still have care of, even though he sees a GP in the primary sector. Next slide, please. So a shared care approach. Next slide, please. So what is a shared care approach? It is care that is provided collaboratively by the primary healthcare provider, whether that be a GP, practice nurses, or practice manager, and in this situation, with our service, drug and alcohol specialty services. So there are many areas of health that have developed a shared care approach between specialty services and primary care. Antenatal, oncology, diabetes, hepatitis, and HIV have all developed this shared care approach, both in the private and the public settings. Both the specialist and the primary care provider maintain involvement in the patient's care, and the aim is to provide a high quality of care to the patient by improving access, communication, and reducing stigma. Next slide, please. So what does it look like? Well, we're already doing a lot of components of shared care. However, we want to improve and build on it. We want to start at the beginning with any new referral. So if a patient has a nominated GP on referral, permission will now be sought from the patient to contact the GP after their first presentation. There will be regular handover occurring between Newcastle Pharmacotherapy Service and the GP during the stabilisation, as well as the maintenance phase of the patient's treatment. The GP will then be consulted when the patient is ready to be transferred, and for their care to be ongoing with the GP. And we want to be able to work together in order to give these patients the best possible care. That might mean taking over prescribing opioid treatment for the patients whom you're already seeing for the other healthcare needs. We don't want to leave GPs to feel out of their depths. We want to be able to support them and to help you manage your patients appropriately and safely. We completely acknowledge that every GP has a different skill set and interest. We acknowledge that some will be experienced and happy to prescribe, while some or others may not feel so comfortable in doing that, and they will need a higher amount of support. Next slide, please. So some things that we are able to do for you in order to help you care for your patient on opioid treatment. So we're able to provide a dosing point as necessary. We're able to complete a specialist nurse assessment and medical review as necessary. Telephone support, information and education. We're able to be a locum for the GP if no other GP in the practice can be a locum with some notice. We're able to be available in the background at all times if needed. And we're a responsive service to the needs of GPs, allowing for a timely referral back to our service, meaning that if a patient, for whatever reason, destabilizes in the community, we'll be able to take them back over without a waiting period as such to stabilize them again. Next slide, please. So what are the roles of GPs in opioid agonist treatment? Next slide, please. So what are the benefits of prescribing for your patient? So taking over the prescribing care for your patient who is on opioid treatment means that the care is not fragmented. It becomes holistic, therefore improving the quality of care. It provides enhanced access for those with severe illness to be brought into care, which benefits the community as a whole. There's less criminal activity, there's less spread of bloodborne viruses and less deaths. It improves and builds on partnerships in local communities to prevent and reduce alcohol and tobacco and other drug-related harms. It provides evidence-based care. Increased access to pharmacotherapy has demonstrated to reduce drug dependence and reduce health and social and economic harms to the individuals in the community arising from unsanctioned opioid use. And the patient is appropriate for primary care as they're in remission for their opioid use disorder. Next slide, please. So, did you know that GPs can have up to 30 patients? That's 10 patients on methadone and 20 on buprenorphine without any further training. So interestingly, that poll that we did at the start of the session, that people felt that unaccredited GPs were unable to prescribe methadone. So unaccredited GPs can prescribe methadone, and there's a certain number of patients that they can prescribe for. However, if you do wish to do some further training, there are some great free educational training programs online. One of them is through the OTAC website, which is the Opioid Treatment Accreditation course run by the University of Sydney. Another one is through the Royal Australian College of General Practitioners, which you'll all be aware of. Another one is through NUA, which is the New South Wales User and Age Association. And it's really important, I think, also to point out that opioid dependence is similar to other chronic medical conditions that you manage every day. And opioid agonist treatment is mainstream treatment delivered in the primary healthcare setting in Australia and in many other countries. Next slide, please. So opioid use disorder is a complex ongoing issue, and as discussed before, we want to put each patient in the best setting for them to get the best possible outcome. We want to normalise patients to receive care for the opioid dependence in a primary healthcare setting, like any other chronic health condition. And as like other chronic health conditions, there are guidelines that can be followed. So the New South Wales clinical guidelines were written as a guide for primary healthcare providers, specifically to support GPs in their management of their patients with opioid use disorder. We have adapted these guidelines into our practice, and they're a great resource for anyone to use. Next slide, please. So remember Dave. So he has a job, he has a mortgage, he has kids, and he's stable on opioid agonist treatment. So we are a specialty service that see and treat a multitude of people with very different treatment needs. We see people who live chaotic lives using polysubstances, have recently been released from jails, all the way through to people who work full time and haven't used substances in 10 or so years, pay their pharmacy bills up front, turn up to appointments, and or are easily contactable via phone for reviews. The latter of these people are who we believe should be receiving their opioid agonist treatment in a primary healthcare setting. These are patients who you're already seeing for the other healthcare needs, people who already turn up to appointments and pay appropriately. The reason why I'm telling you all this is because we acknowledge that what our view of a stable patient might look like could be different for what your view might look like in a primary healthcare setting. So it's why we ask, what do you think a stable patient looks like in general practice? Next slide, please. So to summarize my long presentation, about one slide is basically one, that stable patients can be treated by their general practitioner in a primary healthcare setting with or without our support, but we're going to give you our support. Two, we have developed a shared care approach to assist primary care settings to treat these patients, and we'll be keeping you informed of progresses and issues, even if your patient is receiving care fully from us. Three, if you have a patient who is on opioid treatment, please consider taking over their prescribing care, and we will be here in the background. And four, that New South Wales Health Opioid Treatment Guidelines are a really great resource for primary care providers. Next slide, please. And that's it from me. Thank you.
Thanks, Emma. Now we have John Jones on how pharmacists can work with GPs and assist with opioid treatment.
Okay, thanks, Lauren, and it's a pleasure to be here to speak to you tonight about how can we work together as a team to help these people obviously come from difficult backgrounds and who are trying to get their lives back together. So I'm delighted. Hopefully I won't bore you too much because a lot of my talk is about the practical aspects of what we need on our prescriptions, the stuff that I hate, the sort of legal and boring stuff, but obviously it's very important if we're going to be able to help these people. Next slide, please. Okay, so yeah, a little bit about me. My background is I played rugby league, and so I've always been involved with teams, and I like this approach to care, working with sort of other health professionals in the team to help the people that we look after. I worked as a dietitian for a long time, and then went back to school to uni to complete my Master of Pharmacy, and so I've been working as a pharmacist now for about 10 years, and recently an owner of a pharmacy, which adds another dimension of stress. So not only worrying about making sure we're looking after people, but all of the other stressful things. Next slide. So I thought I'd introduce a couple of people who we look after, and I've had their permission to talk about them. And I'm just intrigued about the background that these guys come from. And, we've heard the statement, you can't understand someone until you've walked a mile in their shoes. And over the past, few months and years that I've been, helping look after these patients, hearing their stories of what they've been through, you can appreciate how they have, gone down the path that they had, spending most of their life, either in prison or in jail, having to deal with childhood trauma, and in Darren's case, telling his story of being stabbed in prison, and almost dying, and having undiagnosed mental health conditions and trying to cope, and obviously using different drugs as a coping mechanism, and coming into the service where he's trying to get some stability in his life. Next slide. So today we'll be covering navigating the regulatory framework for opioid dispensing, and so that will be about what we need from you as GPs and prescribers in order for us to dispense opioid replacement therapy, be it methadone, Suboxone, or the depot injections. Working collaboratively as part of the team, and in particular as pharmacists, our role, we see these patients very, very frequently, and so it's particularly important for us to be able to have timely communication with you or other people in the team, because often some of these issues can escalate, and so really important that we're able to identify and communicate with you guys and the other people in the team. And then lastly, I'll try and outline some of the future roles for pharmacists in opioid treatment, and what we can do to contribute. So I thought I'd also introduce another guy who has been a character in the pharmacy. He grew up living in Western Sydney, had a Maori mother and a Lebanese father, and so he spent much of his, again, younger years living in very challenging environments, and just seeing his progression. The artwork that you can see in the photo is one that he had painted, and so we've hung it there. That's our dosing room in the pharmacy. We've put that in as a way for our methadone patients to be able to dose privately at the back of the pharmacy, where they don't have to be subjected to other people looking at them or judging them. But it's a great piece of art. Next slide. So as far as regulation goes, the areas that we are mostly concerned about from your point of view is the prescribing and monitoring. In pharmacy, it's about approvals, who is able to dispense methadone, what training is required, and what actions have to take place in dosing patients with methadone. And then also patient considerations around observation of intoxication, fitness to drive, and safety, not just of the patient but the community as well. Next slide. So authority to prescribe opioid agonist treatment or replacement therapy. An authority to prescribe must be obtained prior to prescribing. So as Emma mentioned earlier, you will need to contact the pharmaceutical regulatory unit in order to get an authority to prescribe. It's important to note that it's not the pharmacist's responsibility to check that that is in place. So there have been, and there are prescribers who may not realise that this is something that has to happen. So it's important that as part of that process, your first steps is to contact the PRU and get that authority. You must also apply, and this is an important consideration as well, for any other S8 drug for a patient. And again, because we haven't had real-time monitoring, it's made it very problematic in order for us to see what other medications the patients are currently on. If you're going on leave, it's also important that you notify the PRU of those arrangements and the prescriber who will be taking over the care of your patients. Next slide. So what do we need to have on a prescription? And many of you would be aware of the legal requirements for the S8s, and this same regulation applies to the opioid agonist treatment. So obviously we need the name of the patient, and it's important that this has to be, if not generated on a computer script, has to have it handwritten. You can't stick a patient address label on top of the paper-based prescriptions. It needs to be handwritten and legible. You need to have the substance name or the preparation containing it, the strength, and in the case of some of the Suboxones, this is one legislative change that's allowed. So normally on an S8 prescriptions, you'd be aware that you're only allowed to have one medication included, but in the case of opioid agonist treatment, it is allowable to have more than one strength, particularly when a patient may be increasing their dose, decreasing their dose, or alternate dosing. So quantity needs to be in both words and figures, and adequate directions for use. This is particularly important when we're trying to interpret what the doses are, and if there are any change. A time interval if there are repeats, and obviously in the case of S8 scripts, they have a 6-month expiry, but also and the expiry may be different for these particular prescriptions. Next slide. As I said, a buprenorphine script can include multiple strengths of the same drug. It's also important that the number of takeaway doses are allowed. Normally, when a patient is first transitioning into the community, there aren't any takeaway doses allowed, or takeaway doses allowed only for pharmacy closures. So it's really important that that's specified clearly on the prescription, because it often creates a lot of issues with some of the patients. They don't necessarily understand what's needed, and if there's any misunderstanding, we're often the ones who are subjected to their frustrations about that. So it's really important that that's clear. The number of consecutive takeaway doses should also be included on the prescription. So often patients will only be limited to no more than 2 consecutive days, or depending on how stable they are. In the case of some of this buprenorphine, naloxone, the number of takeaways is often greater than that, depending on how stable the patient is. But it's really important that that's clearly written on the prescription. Next slide. If prescriptions are sent via phone, fax or email, it's important that they're sent immediately to the pharmacy. We are required by the PRU to notify them if we haven't received that prescription within 7 days. It's really important that you don't hand that prescription to the patient. This is one of those situations where a patient could present to another pharmacy. It would be unlikely, or that particular pharmacy would dispense it. But it is important that that prescription is not given to the patient and then it's mailed to the pharmacy. In the real world, this notification probably doesn't happen, because these days with Australia Post, they don't send the mail every 7 days anyway, so it can extend past that. But most pharmacies, we have procedures in place where we look at those owing prescriptions to make sure that we receive them in a timely manner. It's also really important that if there are changes made by phone, additional doses, that we receive a prescription in order for that order to be filled. So even if the patient may have an additional takeaway, we will need to have written documentation or a prescription for that. Next slide. So how do you initiate a patient into a community pharmacy? So I guess the first thing is to contact the pharmacy, either by phone or email, outlining whether or not that pharmacy is able to take on that patient. And in particular, some pharmacies may not have a particular type of opioid, whether it's Biodone or Methadone. So just finding out from them what program they may have. You need to send a recent photograph, date of birth and dosing details, and it's important that we have those details so that we can identify the patient, because we don't necessarily know the patient. Obviously the valid prescription and any additional information that's needed. So, and as I said before, important not to hand to the patient. Next slide. So obviously there's requirements for you to be able to prescribe, and for pharmacy, We have regulation around which pharmacies are able to dispense methadone or opioid agonist treatment. This is regulated by the PRU, and new pharmacy approvals are required to have a PBS approval. However, there are some older pharmacies who are methadone dispensing that aren't PBS approved pharmacies. The maximum number of patients that we are able to dose at a pharmacy is 65. So generally speaking, most pharmacies would be 20 or 30. It's depending on the demographic of the area, and mostly that's related to, I guess, the congregation of people in an area that can be a problem in communities where you get 20 or 30 people standing around waiting for their dose. Next slide. Funding. So I guess this relates to the payment and how it's funded. So the opioid agonists are all funded by the Commonwealth. So they are provided at no charge to the pharmacy. However, as with all S8s, there is a high level of regulation, and so the paperwork and other things to document is quite high. So the fee for a patient dosing generally ranges from around $30 to $50 a week. For methadone or Suboxone, that may be different, and that's basically made up of the pharmacist's time in dosing, compliance and documentation, cost of the consumables, so takeaway bottles and dispensing equipment that's needed, safes for holding the methadone, and software as well. Most of the pharmacies who are dosing these days use electronic software to keep better records, I guess, of dosing. And yeah. So next slide. So when a patient presents to the pharmacy to be dosed, there's a number of steps that we need to make sure that we're identification of the patient. And again, most pharmacies will have photos of the patient to particularly help with locums and other pharmacists who are working, assessing their fitness to dose, so looking for signs of intoxication, whether or not they've had takeaway doses or missed doses. And this can be problematic, particularly when you're looking at signs of intoxication, because some of our patients are also on antipsychotics or other medications, which can change the presentation of the patient. So trying to make that judgment at times challenging, and also whether they're using other medications or illicit drugs as well. It's important that we observe the dose, and so part of that is particularly making sure that the dose isn't diverted. I have some terrible stories of patients who have had Suboxone films that have dissolved and in their mouth, and later on spit the buprenorphine out, and so it is an important part of our job to make sure that dose is being taken correctly. Negotiating takeaways and documentation, and this is often a difficult part of dispensing, particularly around the number of takeaways that the patient's been given each week, and fitting in with public holidays and public pharmacy closures. Next slide. So missed doses and intoxication, what's our responsibility as pharmacists and what do the guidelines say? So if a patient's missed between 1 and 3 doses, the pharmacist is able to dose if clinically appropriate. So if the signs of withdrawal are reasonable and the patient's not unwell, we can make a clinical decision to continue dosing that patient. If between 4 and 5 doses are missed, then we will contact you to get advice about the recommencement dose for the patient. And often it's a 50% reduction, but it's again up to your decision and clinical assessment of the patient. If more than 5 days have been missed, then it's generally a case of reinducting the patient back onto OTP. If a patient presents intoxicated, then in this case, the patient shouldn't be dosed in the pharmacy and referred back to you. So, next slide. Takeaway doses generally, as I said earlier, aren't given during the induction stage, and this can last up to 3 months. And the limit, according to New South Wales Health PRU, has been 4 takeaways a week. However, during COVID, this has been increased to reduce the number of dosing times in the pharmacy to help with reducing that risk. It's important that changes to takeaways can only be made by the prescriber, and patients will often try to negotiate this in particular. It's also important that prescription doesn't add that a takeaway dose is to be diluted with water. Some prescribers used to put this on the prescription, but it's important that that's not added, as it's not considered to be an appropriate diluent for methadone. Next slide. So, working collaboratively, I guess the patient's at the centre of care of what we're doing, and again, because we're seeing these patients so frequently, it's important that we have the opportunity to communicate with either yourself, the caseworker, or psychologists and social workers. We often see these patients when they may have issues around accommodation. They don't have somewhere to live, and so because we're seeing these patients so frequently, we're able to make contact with the social worker, or particularly at the clinic in town, letting them know if a patient's having problems so that they can get the appropriate care. I personally had a number of patients who have started to present with sort of delusional thoughts and were saying things that sort of didn't quite make sense. And so being able to communicate that to yourself or other members of the team is particularly important. The case that the patient ended up being admitted into hospital after a psychotic episode, but during the early stages, you could see some of those things, thoughts and behaviours didn't make sense. So again, it's important that we're able to work as a team to help improve the care of these patients. Next slide.
Hi, John. I'll just let you know we've only got a couple minutes left for your presentation.
Okay. Yep. All right. Almost done. So some of the outcomes that we've got for effective collaboration is obviously, as Emma said, the take-home naloxone program, overdose and withdrawal. So being able to, again, get timely communication to you. And that's important. If we have patients that turn up late, or have missed doses, being able to be in contact with the prescriber is important for us to help minimise any aggressive behaviour or problems with the patient. Next slide. So again, trying to keep patients connected. It's identifying those social issues, trying to help, particularly in the community, about the ability to dose at different times so that they can continue to have income and working. Relationship issues, particularly around family and abuse. As I said previously, identifying some of the mental health that often is a comorbidity, accommodation as well. Our role in just trying to keep those areas of the patient's world together. Next slide. And the last thing, I guess, is about the pharmacy. It's about creating professional service areas and providing a professional service for those patients, so that it's an area where someone coming in can feel like they're being listened to and cared for. And so I think that's an important part of our role, and removing the stigma around opioid replacement therapy. So that is the end of my presentation, and thank you for listening.
Great, thanks very much for that, John. Your presentation was a really great summary on the legal aspects. And thanks to all the attendees for your questions so far. They'll be asked and answered after our final presentation. So now we have David Outridge on the best practice for opioid treatment therapy in general practice.
Thanks, Lauren. I'll just try to make sure my sharing is happening. Can people see that? Here we go.
No, not yet.
Yeah.
I can see it.
Here we go. Thanks very much, everyone, for coming this evening after a long day. And it's hopefully at the end of this my talk, you'll be able to identify pharmaceutical opioid use problems, which I'm sure you can already, but also understand what options are available and just the essentials of buprenorphine treatment, which is really probably where most GPs would be going in the first place. You're aware that there's two groups of people with pharmaceutical opioid addiction, ones that sort of come unstuck during medical use, and these people find that they can cope better when they're on opioids, and that leads to sort of a general progression towards addiction in some patients. But there's also non-medical drug pharmaceutical opioid use. How do people get these medications? They can get them over the counter, but there's also leftover medications, relatives. I heard a patient term that as fossil farming when they can't get medications from elderly folk. But non-medical use of pharmaceutical opioids is the second commonest illicit drug use after cannabis. So 1 in 20 adults use pharmaceuticals for non-medical purposes. Opioids are more common than benzos. It's more common in people with mental illness, chronic pain and psychological distress. And it tends to be more common amongst Indigenous Australians, people who are disadvantaged and in very remote areas. So that's the non-medical pharmaceutical use. That's people who for it's over the counter or it's not prescribed for the patient. But addiction can develop in up to 20% of people on long-term opioids for chronic non-cancer pain. Quite an astounding statistic that's only become evident in the last few years. And risk factors include a complex clinical picture, that is impairment physical impairment, psychological impairment, use of psychotropics, and the risk ratio is 8 times for that sort of person. Also cluster B personality traits, people with a history of trauma, complex trauma in childhood, particularly child sexual abuse. 90% of our methadone clients have experienced child sexual abuse, and that's a statistic worldwide. Mental health conditions such as childhood ADD, OCD, mood disorders and psychotic disorders, certainly family history imparts a greater risk, and obviously a personal history of illicit substance use or treatment increases the chance of becoming addicted. So how will these clients present? Well, you may get a phone call from the hospital staff from injecting related sepsis, possibly a near miss overdose, or some acute gastrointestinal hemorrhage or renal or liver damage. And this was quite common during the codeine, over-the-counter codeine days, but it still occurs due to the presence, large intake of paracetamol and ibuprofen. I've got a patient who, a very sensible young man, who was taking 120 ibuprofen, combination ibuprofen tablets a day before he had a GIH. You may get a phone call from the police, and tragically, then people do come unstuck and die from pharmaceutical opioids. You may get a call from a colleague or a pharmacist. You may search my health record and discover people have been seeing other doctors. Unfortunately, private prescriptions don't seem to show up on the medication lists. And aberrant drug use behaviour. So let's just look at opioid overdose deaths, and this is a graph of the death rate for different types of opioids. It's important to note that 70% of the opioid deaths in Australia are from pharmaceutical opioids, not heroin, and the vast majority are accidental rather than suicide, and 50% occur in our chronic pain patients. So half of the opioid deaths in Australia are occurring in patients with chronic non-cancer pain or cancer pain possibly, who are on pharmaceutical prescribed opioids. This top dark blue line represents the morphine and OxyContin, that's the natural and semi-synthetic opioids, and you can see it's been progressively increasing and possibly decreasing the past few years, but the latest figures out of the US is that during COVID, the overdose rate has gone up by a staggering 30% in 2020. So we could expect that this has gone up in our country too. The light blue line is heroin overdose deaths. And you can see, even though the pharmaceutical opioids are reducing, the heroin deaths possibly increasing. This has also been observed in the US, where regulations to control pharmaceutical opioids has been then matched by increase in heroin and illicit fentanyl and fentanyl analogues related deaths. This dark brown line represents synthetic, such as fentanyl and tramadol overdose deaths, and this is methadone here, which includes phyceptone and liquid methadone. So how do we diagnose addiction? So there's overdose deaths, there's also addiction, which is part of that process of becoming increasingly focused on the opioid and taking greater risks. And there is 11 criteria in DSM-5, and you can grade it from a mild to moderate to severe addiction or opioid use disorder. I tend to, just as a rule of thumb, group into 3 groups of these. One related to loss of control, as evidenced by unable to stop or cut down. When you go to use something, you end up using larger amounts and a lot longer than you intended. So one drink isn't enough, so and it ends up a binge. And using despite the knowledge of hazards and harms, so hazardous situations, knowing it's doing you harm, and problems occurring socially, getting drunk and getting embarrassed, or that kind of thing. So there's loss of control group of symptoms. Then there's things you can say is objective evidence of harm, such as things that used to be important to you are no longer being pursued: social, occupational, recreational activities, and then actual failure in responsibilities, family, educational, work, and then just the sheer amount of time spent procuring, using, and recovering from substance use. That's another objective factor. And then you could say subjective would include craving and possibly tolerance and withdrawal. It's probably stretching the word subjective a bit, but it's important to know that tolerance and withdrawal don't apply to prescribed medications under DSM-5, but craving is the key symptom. So loss of control, objective evidence of harms, and craving. So aberrant drug use behaviour is what a patient may start to present with who are a chronic non-cancer pain patient. And this is a list of minor aberrant drug-related behaviours that is not necessarily correlated with addiction. Aggressive complaining about the need for more drugs. This could be craving, but also could be the pain isn't managed optimally. Drug hoarding during periods of reduced symptoms. Again, this is it's hard to relate it to those criteria of addiction, but possibly increased time spent and reducing important activities while accumulating drugs. Requesting specific drugs is craving, possibly tolerance. Openly acquiring similar drugs from other sources that's unable to cut down, and unsanctioned dose escalation, tolerance, possibly loss of control, unapproved use of the drug to treat other symptoms, again craving, using despite the known social harms. So essentially these are relatively minor aberrant drug-related behaviours that you probably are familiar with in some of our chronic non-cancer pain patients who are using opioids. But more major aberrant related behaviours such as selling prescriptions, forgery of prescriptions, stealing, borrowing drugs from others, injecting, getting drugs from non-medical sources, that is people who are selling pharmaceutical opioids, concurrent use of other illicit drugs or alcohol, non-sanctioned dose escalations, multiple, so not just the occasional mishap, but multiple episodes of prescription loss in inverted commas, repeatedly seeking prescription from other sources, deterioration in function at work, family and socially, and a resistance to change in therapy despite evidence of adverse effects. So these are clearly more serious and they correlate strongly with addiction. So someone who has a mildly aberrant drug use behaviour, what do we do about that? And I guess there's two ways to go with people with mild addiction, and one is deprescribing, and you'd be familiar with Hunter Integrated Pain Services approach there, where people are encouraged to learn other ways to manage their pain. Stage supply is a key technique to help people to manage their supply, to reduce and not escalate their use of substances, and gradually decrease in the dose over time, psychosocial and physical therapies. But then if someone has clear opioid use disorder of the moderate to severe, then opioid substitution treatment is indicated because it provides tolerance and blockade, so it prevents overdose essentially by maintaining a high tolerance or blocking the effect of additional opioids. Opioid substitution treatment uses medications that are long-acting and therefore don't give you such a high, it's not such a high and low effect, it's less reinforcing. It's also controlled by legislation, and therefore really you can't go too far wrong if you stick to the rules. And that protects you from the pressure of the patient. And monitoring is much more intensive with opioid substitution treatment. As I mentioned before, take-home naloxone is on a prescription and is on the subsidised list. So how do you decide whether someone needs a deprescribing approach or opioid substitution approach? each individual patient, you just need to look at these different factors, such as the severity. Is it anything more than mild? Has it been going for a long time? If it's been well established and going for a long time, then you may need to consider opioid substitution treatment. Is there a risk of overdose from a high oral morphine equivalent? Anything over 100 milligrams of oral morphine equivalent has a much higher risk of overdose. The presence of other sedating medications such as pregabalin or benzodiazepines, the use of alcohol. What is at stake? If someone's at the risk, at the point of losing their marriage or their work or severe mental health issues, then it may be better to just put them on opioid substitution treatment and get things under control quickly. And if there are multiple addiction promoting factors such as personality disorder, people with antisocial, borderline personality disorder, that cluster B complex, people with trauma, complex trauma, those mental health conditions, and obviously a personal history of illicit substance use in the past. So these would tend to push you towards an opioid substitution treatment. We've seen what the options are. There's liquid methadone. That's not Pharceptone. Pharceptone is the tablet form, as you know, and it's probably the most dangerous oral opioid you can prescribe, and which we'll explain later, but it's because there's such a long half-life, and person's levels can build up, especially in the early stages, and even though their daily dose may be the same. But the effects of opioid substitution treatment is a 3/4 reduction in mortality. And if you think of 2% per year dying, in a 25-year history of opioid use, that means 50% will die. And that's what we tend to see in people in their 40s. Most of their friends have died, or many of their friends have died. If you treat 66 patients, you'll save one life every year. It reduces morbidity and mortality, and psychosocial stability is provided. Now, the key thing to know about buprenorphine versus methadone is, in terms of safety, is summarised in this slide, and this is what the difference is between the two. This is fentanyl, but it's a pure agonist, and buprenorphine is a partial agonist. So you could say this would be the same as methadone or OxyContin, morphine, heroin. Essentially, the higher the dose, this is the ventilation rate on one side. The higher the dose, eventually you'll stop breathing. The higher the dose of buprenorphine, you will reach a plateau where your respiratory rate drops to, say, half of what it was, but you won't stop breathing. Obviously, you can still overdose and die on buprenorphine by adding in other sedatives, but this creates a great degree of safety. So let's look at methadone first. It was the first opioid substitution treatment discovered in the 60s. It was highly researched. It's probably researched as much as penicillin. It's effective. There's good retention in methadone treatment, slightly better than buprenorphine, and it also is cheap. It's suitable for people with very high tolerance opioid levels. So people who are really serious heroin users who are spending, say, $500 a day, or people who are on massive doses of oxycodone, they may be better off being started on methadone. It also tends to be observed that it's better for people who are more traumatized. Buprenorphine is much more clear-minded. Methadone is a bit more analgesic emotionally, but it has a very long half-life, which is very variable from individual to individual, and therefore during the initial phase, the blood levels increase, so there is a risk of overdose. So we only increase the dose every 5 half-lives, which is about the minimum is every 3-day interval. So we only increase by 5 milligrams at the 3-day interval maximum, and that protects people from build-up in the blood from the long half-life. Buprenorphine, on the other hand, is a very safe drug, as you've seen, but it's slightly tricky to initiate. It's a partial mu agonist and antagonist, and its maximal effect is about same as 40 milligrams of oral morphine or methadone. It is a high affinity to the mu receptor, so it actually sticks harder, more strongly than other opioids such as oxycodone or heroin or methadone. And so it will not only produce a blockade effect when it's in a sufficient dose, which protects very well from overdose, it also will actually kick off the other opioids and can cause a precipitated withdrawal if we're not careful. But it does have this other effect called a kappa receptor antagonism. It's a very interesting effect, and it seems to have an anti-tolerance effect. Those people don't seem to crave a higher dose, and there's a less escalation tendency. And some of these funny receptor effects produce surprisingly good pain management despite the ceiling effect of about 40 milligram of oral morphine equivalent.
Hi, David.
So
sorry, David. Just letting you know, we've just got only a couple minutes left.
Okay, right. So methadone, its initiation requires you to be OTAC accredited, whereas buprenorphine may be initiated by unaccredited. Once established, it's more difficult to go back down to buprenorphine, whereas buprenorphine being at 40 milligrams, you can go up to methadone. It's potentially more dangerous methadone, whereas buprenorphine is very safe. There's more restriction on takeaways. Buprenorphine is less restrictive. So if you're going to start someone, start with buprenorphine, but methadone can be started by in conjunction with a specialist or an accredited OTAC provider. So the key concepts with buprenorphine prescribing I want you to impart to you is the idea of receptor occupancy versus the idea of the total morphine agonist effect, and therefore the potential for withdrawal during induction and how to time it. So I've got a couple of diagrams which I hope will be understandable. This just shows the receptor occupancy with the different oral doses of buprenorphine, and it's actually receptor vacancy. So at about 2 milligrams of buprenorphine, you've got about a third occupancy. If you give a whole strip, that is a small strip or a quarter of a normal strip, if you give a whole strip, then you've got about 3/4 occupancy. So if you give someone on methadone, say a whole strip of buprenorphine, they'll immediately drop down to about 3/4 of their opioid effect, and it would cause withdrawal. So the idea is if you're going to be starting someone on buprenorphine, you use lower doses. Now, this is a diagram of opioid receptor occupancy in this dark color, and the red line is the overall opioid effect. So in, say, a long-acting opioid like methadone, because it's a full agonist, the opioid effect is the same as the blood effect. But if you were to start someone on buprenorphine, then it immediately displaces, because of the opioid occupancy, it takes over from methadone, but its agonist effect is only, say, half of what its occupancy effect is, if you like. So it's partial agonist. So that's called a precipitated withdrawal. If someone's on heroin or a short-acting medication like, say, Oxynorm, then every day they're going high and low. They're going into sort of a degree of withdrawal between each dose. This kind of patient, you can actually start directly on buprenorphine because they already are in withdrawal at some point, and they'll actually feel better. Use of the clinical opioid withdrawal scale is useful to, if a person has a score of greater than 12, it indicates moderate withdrawal, and they may benefit from a small dose of buprenorphine. We used to do this. We used to change people over from a long-acting by giving them time to come down to a degree of opioid effect or agonism that might match the buprenorphine, but unfortunately you often still get a bit of a bump, even though you might give them time to come down. This is often done in hospital. Unfortunately, this period here often destabilizes people and causes increased pain. So what we've tended to do is and this is often done in Lakeview, we use a microdosing approach where you keep going with your long-acting, but then you have very small doses starting of buprenorphine and gradually increase, which sort of causes a nice gradual induction. And this can be done over 2 weeks, 1 week or 2 weeks, and it's quite tolerable. So induction of buprenorphine depends on the existing opioid, the long-acting or short-acting, how tolerant, that is how high their tolerance is, and the timing. Looking for the presence of withdrawal. The level of anxiety of a patient is very important to take into account. And your initial dose should be on the low end. So if a person is in well and truly established withdrawal with a short-acting thing like heroin, then 4 + 4 during day 1 is quite safe. If you suspect that they may go into withdrawal, then just stick to the small doses. Then the long-acting buprenorphine injection is really a game changer as well in terms of just lowering the risk. So it's a monthly injection, no daily dosing. It's relatively cheaper than picking up your medications daily, weekly. It's transition to it via sublingual morphine. There's no risk of diversion or selling takeaways. Buprenorphine strips are currently going in jail for $1,000 a strip. It's a lot of it makes its way into the black market, and so long-acting buprenorphine is good for this. We see a lot of people saying that it gives them more stability. Mention it's cheaper. It can be administered by a GP or a pharmacist. I think John has got a project going where he's got a nurse there and they're able to give that medication. There's 2 companies, as we've seen, and it's guaranteed blockade. Therefore, the person's less likely to use on top of it. So with methadone, people will sometimes or buprenorphine save their dose up, get themselves their levels down a bit, and then use something like heroin on top. So yeah, long-acting buprenorphine is certainly the way to go, and that's the end of my talk.
Thanks very much for that, David. Now we've got a few questions for our presenters. So I just want to start with asking Emma Penny, can you explain the informed decision-making you undertake with your patients around the long-term goals of treatment and once they've been handed over to the GP? Do you tell these patients that their treatment is lifelong, or are they advised that they will or should have an eventual transition to zero pharmacotherapy?
So thank you for your question. I am not a prescriber, so the conversations that the prescribers have with the patients when we start them on treatment would be different to maybe the answer that I might give you. I can give you an overall answer. So every patient has a different goal of what they would like to do with their treatment. Some would like to just feel stable for a bit and then reduce off and not be on anything. Others have been on treatment for 20, 30 years and are happy to stay on treatment ongoing. Others get to an age of say 60 and decide that they no longer want to be on it and try and reduce off. So we don't tell people how long they should be on it. We try and encourage people to stay on it for a period of time to stabilize appropriately. If they were to be moved out to their GP, it would be then based on, again, what their own personal goals were. That makes sense. Yeah.
Great. And we've had another one come through that says, of the 1,500 annual deaths related to opioid overdose, do we know what percentage have methadone in their post-mortem toxicology?
I did just look this up, so I don't know this off the top of my head. I will say that. But so I had a look, and from the Paddington Institute report from 2019, so out of the 1,500 1,500 drug-induced deaths, and that's not just opioids, there was about 900 that were opioid related. From the 900 that were opioid related, about 20%, so 200 had methadone in their system. About 400 had oxycodone, morphine, codeine in their system, 350 of heroin, and 200 of fentanyl. So that kind of breaks it down a bit. So like how David just said, the risk of overdosing on methadone is greatest when they're starting on methadone, they haven't had it before. And so when it comes to GPs having someone on methadone, we would stabilize them first, and then once they're stable, we send them back to the community.
Great, Emma. I do have a question now for John. What does a pharmacy do if the patient cannot pay their fee?
Yeah, this is a frequent problem, and it often brings up issues. And so in our pharmacy, we use centre pay, so it becomes part of their Centrelink payment. And I guess that removing that conversation is probably the best way to deal with it. Each pharmacy is going to have its own policy as far as pricing goes. So unfortunately, there isn't any government funding to pay for this service in ACT. So in the ACT, the pharmacies are funded by the state government to provide this service. But in New South Wales, we obviously have the free. We don't have to pay for the opioid methadone, but the cost of providing the service isn't covered. So I guess, long story short would be to set up something like that, so patients isn't having to sort of put the money up front each time.
Yeah, great, John. And I do have another question. You mentioned in your presentation about not diluting takeaway doses with water. Is that because there's a preference to dilute with something else, or is it just no dilution at all on takeaway?
No, yeah, so it's an APF thing, so as far as the Australian Pharmaceutical Formulary, so it's a bit of one of those wanky reasons not to do something, so that it doesn't comply. So it's, yeah. And I think it's about more so the sterility of it. So obviously diluting with tap water or it isn't ideal. And look, I'm not 100% sure on the reason for diluting them anyway. If someone's going to be injecting that, I don't know that it's going to be a deterrent. If some of our patients are spitting Suboxone films into cups and injecting it, then I really don't understand that that's going to make a significant difference to that behaviour. I don't have any evidence. That's just my thoughts.
Very great. Thanks for that, John. And I do have a question for you, David. Is there a maximum dose of methadone replacement therapy?
Generally, 200 milligrams is the most you can prescribe, and then you've got to apply to the medical committee of the PRU to prescribe higher than 200 milligrams, and that generally that applies to people who are fast metabolizers. Those have a quicker half-life, and there's I can't remember the percentage, but you can do levels, methadone levels, and work out the peak to trough ratio, and that is then submitted with your clinical assessment. But 200 milligrams, generally people are in the 80 to 120 milligram range.
Great. And if you've got a patient who's stable on methadone at say around 100 milligrams daily, and they've expressed an interest in transfer over to something like Buvidal, how would you go around organising that here in the Hunter?
I think the most straightforward would be referring them to the Newcastle Pharmacotherapy Service, or through to Lakeview would be better. They would be an arranged admission, but there's increasing. I think in months to years to come, we're going to see more of this done in the community. Already in places like Vancouver, where they have a huge problem with fentanyl, like very, very high dose of fentanyl, which is a very high agonist effect, and they're able to use the microdosing technique just at a pharmacy, and the person goes in and gets like 0.4 milligrams on the first day, then 0.4 milligrams twice a day. And like that last diagram I showed you, it can be done according to the patient's tolerance, and so that dose gradually increases. And surprisingly, you wouldn't think so, but someone coming down from, say, very, very high dose of OxyContin can tolerate coming down to that buprenorphine over a fortnight, for example, with surprisingly few withdrawal symptoms. So the short answer is refer to Lakeview for a high dose transfer to buprenorphine, and then once they're on sublingual buprenorphine, then they can be put onto the injection.
Great, thank you for that. And there's just been one final comment that's just come through, just in regards to that question asked earlier about the dilution, especially for you, John. But the comments just said that methadone dilution is required in every state but New South Wales. Do you have any further information about this, John? Or?
Yeah, I wasn't aware of that. So it's my understanding that because it doesn't comply with the Australian pharmaceutical formula, it's not a diluent that's meant to be used with methadone. So I'm intrigued. I'll find out.
Yeah.
I'll get back to you.
There's pros and cons for dilution. I mean, it ruins the street value of methadone by diluting it. It also means you can't inject as much methadone at one time, and so it's theoretically safer. But really, it's only reserved for people who are clearly at risk of selling or injecting. But even then, you're injecting with tap water, so it's not great. So that's why it's really something I think most people don't dilute their methadone, don't request it diluted, but for some clients I do.
Yeah, great. I think we're finished with time now. So I just want to thank all the presenters here today and everyone for attending. And I just wanted to hand back over just for the final poll questions.
Can I just say too,
Thanks.
in the multiple choice question, there's actually two answers that are correct, so, even though it says only one answer. So yeah.
Okay.
Could be confusing otherwise.
Thank you for that. So while we're on the subject of the polls, I'm going to launch them again, and we'll see if we get some different answers than we did at the beginning. I'm just going to share those results. So at the beginning, before the session, we had 83% said yes. And now we have 75% saying yes. And at the beginning, we had 17% saying no. And now we have 25% saying no. So I will just launch the next poll.
it's not.
So I'm just sharing those results. David, did you want to comment on that?
Yes, the answers that I initially intended was to be the correct ones was C and D, but I can understand why people said A, because it cannot be initiated. It shouldn't be really initiated by unaccredited GPs. It has to be done under the supervision of a accredited GP or a specialist. But yes, most people have got the C and D, and the A is understandable. It is methadone is still, you know, the gold standard, the effectiveness and retention. It is still that gold standard, but buprenorphine has so many advantages, particularly in primary care management.
Great. I will just launch the last one. And I'll just share those results.
Can I just say too that the Ministry of Health have said that you can actually put either the mils or the milligrams. You don't have to necessarily put both, because it does get very crowded on this prescription when you've got the typed as well as the written.
Well, I'd just like to say thank you very much to all the presenters tonight. I think it was a fabulous presentation. And I did just want to thank Indivior. They sponsored tonight's event. So thank you very much for that. And one last reminder that we have our ECHO session on the 4th of August, which is also on this same topic. And it's a smaller group via Zoom where we can discuss, have more of a discussion group around this topic. Just another reminder to do the evaluation when it pops up, and that this has been recorded and will be available on our website. Thank you very much, Lauren, for facilitating tonight, and I'll catch you all at the next webinar. Thank you.